Dr. Haitham Bashier, medical doctor, MBH, and PhD in disaster management, preparedness and mitigation. I worked in the area of emergency and humanitarian work for since 2004. Regarding the risk assessment, I have been involved in conducting risk assessment for the EHA department, Ministry of Health, since 2004, but recently more specialized work, and the last one was in 2014. So last time I conducted the risk assessment was in 2014. So mainly public health risk assessment in the context of flooding, as an example of natural disaster. Well, in Sudan, Eastern Sudan, the trigger factor for that is that area was subjected to annual risk of flooding with all the consequences, public health consequences, but still no scientific or thorough risk assessment has been conducted in that area. And that assessment was part of my study, the PhD study. The outcome was like 3 models. As expected with other, during emergencies, there is this problem with data. The data are either not available or inaccurate or inaccessible, and so on. Putting this in mind, we developed our methodology and tools to overcome this problem. So we went for semi-quantitative approach, where quantitative data are there, but we make use of the experts' opinion and views, and we developed our model based on the analytic hierarchic process, AHP, through which we were able to turn the intangible and opinions and into tangible and quantitative data. So it is a very simple tool. It is used in almost all sectors. We have utilized it in the field of public health, in particular during emergencies. What it does, this tool utilizes the opinions and group opinions. It turns like pairwise comparison with 3 levels, alternatives, options, and objectives. It turns those opinions and views, converts them into countable outcomes. Because of the first, personal bias. Second, because our experts were from having different backgrounds, different experiences, including academicians and field workers and decision makers. That tool helped us in overcoming this bias by blending all those opinions, and through its powerful inconsistency detection. Because as we are referring to human beings, their opinions, for sure there would be some sort of inconsistency similar to real life situation. So one of the advantages of that tool, it can calculate the inconsistency of their responses and their opinions. It excludes the inconsistent judgments and opinions and keeps only the consistent one, of course, within a range. It has a very complicated calculations, but fortunately now it is automatically available. Once you enter the primary information or data, the whole process will automatically be generated through a calculator, which is available free, and it gives us the final result. But whenever there is a chance to go for quantitative data feed in that model, our first option is to go for quantitative data. We have used this tool in the to assess the public health risks in the context of flooding in eastern Sudan. We have started by identifying the available secondary data in relation to our chosen examples of malaria and diarrhea as examples of vector-borne and waterborne diseases. First, we have identified the variables ranging from the available emergency health care to referral system, surveillance, drug supply, basic services like safe water, communication, availability of bed nets, and so on. The next step was to select our experts. Those experts were chosen from or selected with different backgrounds, different affiliations, working for Ministry of Health, Federal Ministry of Health, State Ministry of Health, and local health authorities, in addition to WHO Sudan, to guard against institutional bias and personal bias. Then we built our hierarchy where we have identified our objective to reduce or to assess the risk of waterborne diseases and vector-borne diseases. The second level of variables were the direct causes of those risks. Then a second or a third level were added that included the indirect causes. Just an example is the risk of malaria is directly caused or increased by the vector density, then as a direct cause. So the vector density in turn, it is caused by either lack of prevention services or inaccessibility or other. So those are the indirect causes of malaria. So following that, after building the hierarchy, few steps of mathematics were there, and the end result was validated again using the model. One of the outcomes is that we have started with 10 experts, but due to inconsistency, the tool has rejected 2 responses. So we ended up with 8 experts. One additional value is that the tool was serving as a planning tool. Beside the AHP tool, we have also tried another tool, which is a semi-quantitative risk assessment, mainly addressing the continuity of function, like for the public health, primary health centers in that similar area. Because over years, many of those health centers, they stop functioning due to different causes, mainly inaccessibility or direct damage or so on. This is another example of conducting risk assessment using a semi-quantitative method. We have come up with this 6 steps. As we have identified our indicators for hazard, vulnerability, and capacity. The hazard component was mainly addressing the size of previous damage or flooding, the history of isolation caused by water, the isolation of the health centers, days of inundation and isolation, and likelihood of inundation. For vulnerability, we have also selected some variables or factors, structural and non-structural, mainly the accessibility, distance from the health center, time to the health center. Besides the hazard and vulnerability, the capacity was assessed based on the human resources, the availability of drug supplies, and so on. We have calculated those factors and we plot against the previous event, like the stop functioning, and we see which center was mainly or mostly affected, and we read against the retrieved risk components. So we can project that if there is any health center with similar condition, then the possibility of stopping functioning in the next or in the coming flood season is range from 0 to 1. So this tool is available and published in the International Journal of Disaster Risk Reduction. One of the advantages of using this tool is that it needs minimum resources because it mainly depends on the secondary data plus the limited number of experts, not like going for a large number. So because in settings or areas like East Sudan where the resources are scarce, then such model might suit such contexts. So one of the advantages that the minimum resources were needed. However, still there were challenges, mainly because of validation. We needed to expand the application of this model in other areas and for other types of hazards and risks for more validation and testing, because it was used once. But theoretically, yes, it can be replicated. And from my experience in conducting those activities, resources or limited resources is not an excuse to limit our conduction of risk assessment. We as scientists, we are obliged to always come up with innovative and creative, but still applicable and realistic tools, methods, and approaches. One thing that I've realized, the role of other sectors within the domain of health and others, because we need to go for multi-hazard assessment to be more efficient. In real life, the area, yes, it suffered from flooding, but there are other risks. And so in order to come up with a comprehensive risk assessment and to serve those communities best, it is always better to go for multi-hazard, multi-risk assessment. Two is to try to align the existing, there are so many tools, approaches. I think we can together review and at least to come up with more robust, still scientific and applicable tools and methods.